Hi, everyone. I will just talk to you a little bit more about some stuff from delivery room, how to potentially improve how you can care for any baby, mainly born less than 28 weeks gestation. So we'll focus today on respiratory monitoring. I have nothing to disclose except that this is one of my areas of interest. So we heard a lot about this already, that the transition to independent life after birth is basically divided into two things. You have a respiratory transition and a cardiovascular transition. And it is an interdependent sequence of these physiological events, which will help you to transition any of these babies from the fetal to the neonatal state. If any of these things fail to occur, then you certainly have a problem with this baby. You also heard this usually yesterday or the day before, that most babies don't need our help. Around 10%, or depending on what paper you read, need our help. The lower your gestation is, the more likely they will need help. So certainly any 23 or 24 week will need help. A lot of babies have some initial breathing, but they often then stop breathing once we start mask ventilation. And there's a lot of different breathing patterns they use, but most predominantly to rate their lungs, the babies use crying. Um, Now, this is what the baby does, and this is what you have to do if the baby isn't breathing. So you have to figure out a way of clear the lung liquid, establish functional residual capacity or FRC, that then facilitate gas exchange. That's one of the most important, because only if you facilitate gas exchange, you will get an increase in heart rate. If you don't get gas exchange, you will never get an increase in heart rate. Whatever you do, it should stimulate the breathing. You need to deliver an adequate tidal volume, not just a tidal volume. And then what the baby doesn't need to do when it's breathed spontaneously, but what you have to do when you provide respiratory support is you need to minimize lung injury. Now, these are the recommendations, and we heard a lot of them over over the last days. This is what the guidelines tell us what we should do with this amount of pressure, so the PIP pressure and your PEEP. Now, what's the problem with what the guidelines tell you? Well, the guidelines tell you to use a static or set pressure of 20 to 25. And if you look at this paper where they use the self-inflating bag or the TPs to provide positive pressure ventilation, you can see with a pressure of somewhere between 20, 25, and 30, your volume can be quite low and can be quite high. Yeah, that's mils per kilo. So in some of these babies, when the lung compliance is good, you might get, with a pressure of 25, a volume of 30 mils per kilo. And that's certainly not something you would like at birth, and you certainly would never do on the NICU. What's the problem with this? Now, this is an old study back from the 90s, but it shows nicely when lambs were given only 6 inflation with a volume of 35 mils per kilo, instead or attached to the ventilator, the ones who got this high volume, they had problems with lung mechanics, lung injury, and altered the response to surfactant. And if you remember the slide before, you will see that sometimes you give that at birth as well. Yeah. So lung injury is often caused by your high tidal volume, not necessarily because you use the pressure of 30 or 35. So even though we are pressure driven, the volume will be the problem and not just necessarily the high pressure you're giving, it's the high tidal volume. Why is that? If you look at preterm babies, your functional residual capacity is only 11 milliliter per kilo. Your total lung capacity is 19. So you don't have much left to provide ventilation. So if you give too much volume, you get easily some lung injury. Now, this is just what I wanted you to remember. Pressure of 20 to 25, you might get high tidal volume delivery. Now, what can help us? Well, there is more and more stuff coming out about respiratory function monitors. There's many startup companies who have respiratory function monitors. But the latest recommendation, they will tell us that there is not enough evidence yet to recommend against or for the use of this respiratory function monitor. Why is that? That's because there's only like 3 studies available. Yeah. Now, respiratory function monitors, they are great. We use them often daily on the NICU. Like you would hardly see a ventilator without those pulmonary graphics. And there will be another lecture by a colleague of mine in the next session. So we use them routinely. Yeah. But a lot of people are afraid to translate that into the delivery room. Yeah. And I can remember I tried with our respiratory therapists. They were always saying no. So I went one day onto the unit and put black garbage bags on top of each ventilator. And they were all upset because they couldn't see the waveforms. And I said, well, you don't need them in the delivery room, so why you need them up here? And said, well, it's important up here. And down in the delivery room, we don't need it. So I think there's often this disconnect that we don't need it from birth, which is needed once the baby's on in the NICU. So you have a lot of things these ventilator can tell you. Yeah, and these are just a small selection of available ones who can provide you these graphs. What a lot of these do is quite. I think it's great that they display so much, but it's really hard to follow them, particularly when you do resuscitation, to look at all of them. There's newer ones available which are much easier. They just give you a percentage of leak or a cylinder with the tidal volume. Where you're at, which are maybe much easier. So these are a few things that can help you. It can certainly help you with good mask position and tell you if there is a leak. It can evaluate what you do, and certainly when you see the flow goes in and out of your endotracheal tube, you know you're in the right spot. And certainly you will see much more about this in the next lecture, so I will skip through it a little bit faster, but you can see here the pressure doing mask ventilation. This one was done with 30/5. You can see the flow going in, flow coming out, and you can see the tidal volume going nicely in and then back to baseline. So basically 0 leak, yeah, which is great. Now, when you do mask ventilation, we talked about this as well. You adjust your ventilation by assessing heart rate and chest rise. This is what the guidelines tell us, basically. So heart rate is the best. Chest rise maybe is not so good, particularly if you have premature babies which you put in plastic bags. If you have a term baby, yes, you can might more easily see the chest rise, but particularly when you have a baby who is in this plastic bag, you can see here people were asked, do you think the chest is moving? And that was one of my PhD projects. And you can see that many weren't able. They said it's appropriate, it's too low, not at all, or not sure. And these were the tidal volumes delivered. So it's not easy to do. Yeah. And this was done from the head of the bed. And then a different study compared, okay, let's get the junior people at the head of the bed doing mask ventilation and ask the senior staff who stands at the side of the table to see if they can do it. And they were both as bad. Yeah, so just because you work 20 or 30 years doesn't mean it's getting easier when the baby's in that plastic bag. And when you try to judge how much volume you're giving, you can see that 20 people again were asked, and you can see that the red line is kind of red dot is what the volume was they were judging, they were giving, and the blue bars is basically the volume the baby got. And you can see they could be quite small, so quite stiff lungs, or quite wide and high, so maybe a lung with good compliance. So it's certainly a problem when you provide mask ventilation. Now, some of the problems have already been discussed, and I just want to highlight a few of one. A couple of them have just become into our light over the last little while, in particular to this one here, glottis closure, as well as your trigeminal cardiac reflex, which I will mention in a minute. Now, you've seen that on Friday, on the first day, that the sizes we sometimes use for preterm babies, they're not always fitting, so they're often way too large for what we need. And that certainly is reflected in many studies who showed that there is a lot of leak, regardless how well you're trained. You could be, well trained, work for 20 years, do it every day. You still can have a lot of leak. And sometimes you have lower leak and sometimes you have more leak. So it varies also with yourself if you do different babies. Now, this is what I showed before. Now, if you use waveforms and you use them every day on the NICU, you would see that if you just look at the flow and the volume, that this area under the curve is much bigger than this, and the volume goes in, volume comes out, and then the system resets because the next inflation starts. So this is your leak, yeah, and you can see that the pressure is still reached because the leak is only around 80%. So if the leak is not at least 90%, doing positive pressure ventilation, so you will still see your pressures reached, which is certainly deceiving when you look at the manometer on your T-press or your self-inflating bag. What's a problem with those waveforms? If you just use those waveforms, this tiny straight line, this straight line, and this straight line is always 80% leak. So it's the same. It's really hard to judge what is the leak. Now this one is, as you can see, there's not 100% leak because it goes in, just the top bit is your volume goes in, and then this is a straight line. So this is certainly not a good mask ventilation. You can see the pressures is all over because it's not reaching the set pressures. Mask gets repositioned, and then you see a much improved mask ventilation with no leak. So that's one of your steps of Mr. Soper, where you reposition the mask and it improves. Now, if you use a respiratory function monitor, then you can certainly reduce your mask leak. So by looking at it and looking at the waveforms and adjusting it, you can reduce the mask leak. And that's shown in all these three studies which are out there. Now, what all these three studies did, which is certainly not available everywhere, they used respiratory function monitors. Like these two studies used one which is called NM3, and this one down there used a different program altogether. So now they are quite expensive, but a lot of sites would have a ventilator, and you could just have a ventilator in your delivery room, put the ventilator on CPAP, put a test lung onto your ventilation circuit, take the flow sensor, put it on your ventilation device, like your T-piece or your self-inflating bag, and connect it with the mask, and you get all the values onto the screen. So that's a simple, cheap way, so you don't need to buy an extra device, you just use the ventilator. Yeah, so that certainly would be an easy solution if you have a ventilator, because many of them use the ventilator once they intubate or maybe on CPAP as well. So it's not something that you waste. Another benefit is you can turn on the humidity, and then you get warm, humid gas. You might reduce your low admission temperatures as well. That's just something you get there as well. And this is something we've seen before as well in the last days, how to best hold the mask. Just keep in mind, this is just with the Laerdal mask, and this is only done in mannequin, so no one has done ever study if this is actually the best approach in a delivery room, but this is just how they figured it out on a mannequin. Now, a respiratory function monitor is also good for teaching, and there are cheap ones available, or you use the ventilator again. And this one was a study done out of Melbourne where they added the respiratory function monitor doing a course of NRP, and found that when they taught with that course, the mask leak in the participants is significantly reduced. So that's maybe another way to help to improve your mask ventilation. Airway obstruction is often mentioned, and there's several studies who showed that when you provide ventilation, you might get the pressure, but you don't get any gas in, and you get no volume. Yeah, and one way people were trying to do this is using this PDCAP, this colorimetric CO2 device, and they were saying, well, it wasn't changing color; it remained purple. Yeah. Now, there was when was that? 2009. Since then, there's several studies done that it might take a minute or two until you get CO2, just because there's so much fluid in the lung. So maybe they were measuring nothing else than no gas exchange yet. What come to light most recently. And there's something when you provide mask ventilation. This is again this area obstruction. And in this one here, what you can see is that that here the baby is doing some spontaneous breathing, uh, doing this longer breath or some inflation. And here air goes in, but nothing is happening. Yeah. So what's happening is that, and this is something you all know from fetal breathing movements. So when the baby is doing fetal breathing movements, it closes the glottis, so the vocal cords get closed. Yeah. And recently, people figured out that babies at birth close their glottis. So when you provide mask ventilation, you might not get gas in because the glottis is closed. So that's where stimulation might help you to open the glottis. So that's something, if you don't get anywhere, just think about that the glottis might be closed. Yeah. Why is this something which is new? If you look at older studies, they all were reporting every obstruction. And if you look at the latest trial where they looked at all these things, they had zero every obstruction because it wasn't every obstruction, it was closure of the glottis. Yeah. So whenever you deliver positive pressure ventilation, you should assess heart rate and chest wall. We don't measure the towel volume. We use a set PIP, and it will certainly vary, as I've showed you here before. Now, if you use any of these respiratory function monitors, what you nicely can do is you can see, oh, I'm not getting any volume in. My PIP is only 30. I go up to 40. Volume goes up. And in this case, the team went even up to 50 and gathered too much towel volume and then would have decreased the volume again. Now, if you don't had a respiratory function monitor at that time, you would have just continued with that high towel volume. And here is just, another classical example, low towel volume going up, high towel volume too high, coming back down to 20 to get a more appropriate towel volume around 5 mils per kilo. Now, all three studies showed that if you use a respiratory function monitor, you might be able to reduce the amount of volume, high volume, so you might be more in the target range. And all three studies used 4 to 8 as a target range, which was based on no evidence. It was just a suggestion from one of the world experts that that might be the best target range. Now, some colleagues and myself have combined all the studies into a meta-analysis, and what that certainly showed is quite low numbers, that mortality, as long if you use it or not use it, does not change. So certainly that's not something which might be helpful. Hello? So now the title of the talk was does monitoring tidal volume reduce lung injury? Well, it doesn't reduce BPD. That's from these 3 trials. There's more trials needed, that's for sure. But certainly in these 3 trials, when you look at it, it did not reduce BPD. However, what might be more interesting, and this is maybe not a result of using the respiratory function monitor, but it could be, is when you look at brain injury, and this was mainly intraventricular hemorrhage grade 3 or 4, or paraventricular malacia, you can see that was significantly reduced. Now, it certainly needs further studies, but maybe a respiratory function monitor used in the delivery room does not reduce lung injury, but it maybe helps you to reduce brain injury. And there is certainly some evidence out for that. There's animal studies out who show when you use a volume greater than 8 mils per kilo, so if you ventilate a preterm sheep with 10 to 12 mils per kilo, you get inflammatory markers in the lung increased, and then they go into the brain, disrupt your brain blood barrier and causes brain injury in the sheep. So that's certainly something which is intriguing and might need some further studies. That's also confirmed by 2 observational studies in the delivery room. When you ventilated with more than 6 mils per kilo, in a delivery room, you had a 4 times higher rate of severe IVH. So maybe, targeting your volume more closely in a delivery room instead of just using a peak inflation pressure might be something worthwhile doing. Now, one way of doing that, but there hasn't been any studies on that, is if you just attach your mask to the ventilator and set the volume guarantee you would do on the unit. That's an easy way. The ventilator does everything for you. You just adjust as you might go. But that certainly hasn't been studied in a single patient and might need some further studies before that might become a reality. So just to summarize, mask ventilation is a difficult task, so you certainly need to always keep that in mind. You have often leak. There might be obstruction, but it's more likely that your glottis is closed. You could use a respiratory function monitor to help identify some of these things. And it can reduce the total volume it delivers if you use a respiratory function monitor, but it doesn't reduce your lung injury, or your BPD, but it might reduce your brain injury. And that's all I have for this talk. Thank you so much.